I would like to thank Professor Kolpe and the scientific committee for inviting me to speak to highlight our findings from the Global Survey on Sperm DNA Fragmentation, which was conducted by the Global Andrology Forum. Over the next few minutes, I'd like to review the limitations of the male infertility evaluation, and also to briefly provide an overview of sperm DNA fragmentation. I know we've already had some excellent lectures on sperm DNA fragmentation, so I'll just do a brief overview of SDF and associated risk factors, and this will help us understand the results of our survey a little bit better. And then finally, I'd like to provide key findings and expert recommendations from the global survey on SDF. The cornerstone of the male infertility evaluation is the conventional semen analysis. This provides information about pH, sperm concentration, motility, and morphology. But a semen analysis alone cannot completely predict fertility potential. And studies have shown that approximately 15% of infertile or subfertile men may have a normal semen analysis. In order to provide the full fertility potential, we need tests that assess functional competence of sperm. Sperm DNA fragmentation is one of these tests. Several studies have shown that impaired sperm DNA integrity can negatively affect fertilization, embryo development, and ART outcomes. And this can occur from intrinsic and extrinsic factors. Testicular mechanisms can lead to defective maturation and abortive apoptosis, and can manifest as single-strand and double-strand breaks, mismatched bases, or abasic sites. Post-testicular mechanisms can also play a role and mainly have an effect on increasing oxidative stress in the seminal environment, which can lead to immature or abnormal sperm. This figure provides an overview of the origins of sperm DNA fragmentation. SDF results from underlying mechanisms such as defective maturation, abortive apoptosis, and oxidative stress. Clinical risk factors such as age, infection, cancer, hormonal imbalances, obesity, and diabetes can play a role, along with environmental risk factors such as heat exposure, environmental toxins, radiation, smoking, drug abuse, and dietary habits. Despite a growing body of scientific evidence supporting sperm DNA fragmentation and the impact it can have on pregnancy outcomes, there's a lack of standardization in clinical use and in society guidelines. And this really was a driving force behind us developing this global survey on sperm DNA fragmentation, so we could really assess what andrology experts around the world are doing in their clinical practice on this topic. The survey consisted of 64 questions, and we were able to develop 18 expert recommendations from this. There were three main aims to the study: to investigate the global practices related to the management of infertile men with high sperm DNA fragmentation, to summarize professional society guidelines related to management of infertile men with sperm DNA fragmentation, and compare them to our findings, and to provide expert recommendations on the management of infertile men with elevated sperm DNA fragmentation. As we reviewed society guidelines, we realized that relevant clinical scenarios were not being answered on topics of sperm DNA fragmentation. So we came up with expert recommendations based on survey responses and available scientific literature to help address these clinical questions which were not answered by many of the guidelines. And in order to do so, we enabled 63 of our senior experts from the Global Andrology Forum and invited them to participate in the Delphi Consensus. 15 of the 18 recommendations passed in the first round at over 80% consensus to pass. The remaining 3 recommendations passed in the second round of voting. I know this slide is a bit hard to read, so I provided the reference so that you may review this at your leisure. This is a table that provides summarized guidelines from major infertility societies worldwide on sperm DNA fragmentation. The problem we faced when we asked these specific questions that were clinically relevant was that most of the time the answer we got was that there's no specific recommendation. And this applied to unexplained male infertility, idiopathic male infertility, recurrent pregnancy loss, risk factors associated with exposures and elevated SDF, varicocele. What we quickly realized was that there was a paucity of information about SDF in most of these guidelines. I provided the reference for this manuscript as well. And in this study, we dealt with questions such as the general approach to elevated SDF, men that have SDF and varicoceles, what the treatment options should be, the use of antioxidants for elevated SDF. And again, when we tried to answer these clinically relevant questions, most of the guidelines gave us no specific recommendations. We had 436 responses from reproductive experts worldwide spanning 55 countries, including every continent globally. Survey respondents were asked if they ordered sperm DNA fragmentation testing in couples with unexplained or idiopathic male infertility, and the majority of them ordered SDF testing in some cases. Along with our survey results and available literature, the expert recommendations from the Global Andrology Forum are that SDF testing should be considered for all men with unexplained or idiopathic infertility at the time of diagnosis or after ART failure. The survey asked for a couple with recurrent pregnancy loss after natural conception and a normal female partner, when will you order sperm DNA fragmentation testing? And most of the respondents would order this during the initial evaluation. Our expert recommendations also reflected this, suggesting that SDF testing should be ordered in the workup of any recurrent pregnancy loss, regardless of conventional semen parameters. When considering risk factors, exposures, and conditions that would make one more susceptible to increased SDF, the majority of our respondents would order SDF testing in high-risk patients who are above the age of 40, have obesity, previous exposure to radiation, chemotherapy, chemical exposure, or smoking greater than 10 cigarettes daily. Our expert recommendations reflected this, and also included other risk factors such as alcohol and genitourinary infections. All infertile men with such risk factors should be informed that they may be at an increased risk for elevated sperm DNA fragmentation. In the survey, we asked, in an infertile patient with clinical varicocele and normal conventional semen parameters, do you order SDF testing? And respondents were split on ordering SDF in the setting of a varicocele. Our expert recommendations, based on scientific literature and survey responses, suggested that SDF testing may be considered at the initial evaluation of infertile men having a clinical varicocele with either normal or abnormal semen parameters, particularly if ART is planned after failure of medical treatment. Performing SDF testing will assist in the decision-making process of whether a varicocele repair may be helpful. SDF testing should be ordered for men with clinical varicoceles who still have persistent infertility after the varicocele repair. And in regards to a subclinical varicocele, SDF testing should not be performed for this indication. When respondents were asked if they perform SDF testing for infertile men who are undergoing ART, most respondents stated that they perform SDF testing for this indication. Our expert recommendations stated that SDF testing may be beneficial for ART planning in terms of its use as a diagnostic and prognostic marker, especially if there are known risk factors. However, there are limitations with SDF testing, and these need to be discussed with couples. SDF testing should be offered for ART failure or recurrent ART failure, especially in men with known risk factors. We asked respondents how they treat elevated SDF once diagnosed in infertile men, and what duration of abstinence do they recommend in men that have elevated SDF before attempting conception. And several studies have shown that lifestyle changes may benefit men with high SDF values. We know that exposure to environmental and lifestyle factors, including smoking, airborne pollutants, ionizing radiation, and pesticides, have far-reaching implications on male fertility. Shorter abstinence periods have been reported to reduce SDF and improve pregnancy outcome. And most respondents picked abstinence periods of 24 to 48 hours before attempting conception with high SDF. Our expert recommendations were in concordance with this, and we suggested for infertile men with elevated SDF, lifestyle modifications strategies should be implemented, including maintaining a healthy lifestyle to overcome obesity, stop smoking, limit alcohol use, as well as treating infections and eliminating toxins. Ejaculatory abstinence of 12 to 24 hours before attempting conception is recommended. And we felt that it was not necessary to order a second confirmation test in patients that have had high sperm DNA fragmentation. So a confirmatory test is not necessary. In patients that have a clinical varicocele and normal semen parameters associated with high SDF, most respondents would recommend lifestyle changes, antioxidants, and to consider varicocele repair. Our expert recommendations suggested that infertile men with a clinical varicocele and normal semen parameters of varicocele repair should be offered. The goal in this scenario is to lower sperm DNA fragmentation as much as possible, and a varicocele is associated with elevated sperm DNA fragmentation. ART can be performed after varicocele repair if there's no improvement in fertility status. If there's a need for ART to be performed prior to varicocele repair, then the couple should be counseled on the risk of failure that may be attributed to the elevated sperm DNA fragmentation. And other attempts to lower sperm DNA fragmentation should be considered, including antioxidants, sperm selection techniques, and possibly use of testicular sperm. When asked if they prescribe antioxidants for elevated SDF and the duration of antioxidants, most experts stated that they prescribe antioxidants in this setting and do so for at least 3 to 6 months. Our expert recommendations from the Global Andrology Forum are that empiric antioxidants can be prescribed for infertile men with elevated SDF, especially in the setting of known risk factors. A duration of 3 to 6 months can be tried to help improve sperm DNA fragmentation rates. However, overprescribing antioxidants to all men is concerning and can lead to reductive stress, which can actually negatively impact semen parameters and fertility potential. The majority of respondents recommend use of sperm selection techniques, and the most commonly used technique is intracytoplasmic morphologically selected sperm injection, or IMSI. Our expert recommendations are that sperm selection techniques can be used in infertile men with elevated SDF in the case of ART. Multiple techniques have been described, and there's advantages and drawbacks to each one, and no particular technique can be recommended over another. None has shown a clear superiority, and couples should be counseled regarding this. And that much of this is based on empirical evidence. When asked about the use of testicular sperm for ICSI, almost 60% of respondents would consider using testicular sperm, and most would do this after 2 or more ICSI failures. Our expert recommendation suggested that in infertile, non-azospermic men with high SDF, that cannot be corrected with other treatment modalities, and they have a history of unsuccessful ICSI. The option of ICSI with testicular sperm can be considered and discussed with the couple. They should be informed that this approach is based on low quality evidence. Respondents were asked which of the following SDF assays do they order and what thresholds do they use to interpret the results. In general, the tunnel assay was the most commonly used assay. However, this was closely followed by SCSA and SCD. There are 4 main tests that are done for sperm DNA fragmentation, and this includes the tunnel assay, the sperm chromatin dispersion test, the sperm chromatin structure assay, and the COMET test. Unfortunately, there's no universal cutoff value for SDF interpretation, and different clinicians use different ways to interpret this. The current recommendations are that each laboratory should determine and validate its own thresholds. We need future research to focus on establishing a gold standard test with clear cutoff points for measuring and interpreting SDF levels. And this is what the message was from our expert recommendation, that any of the 4 tests can be used, but we need further testing and research to establish cutoff values, and until then, every laboratory can establish its own reference values based on predictive values for fertility outcomes. When SDF testing is recommended, the abstinence period should be fewer than 5 days. When asked about the delay of incorporating SDF testing into clinical practice, the most common reason cited by respondents for their perception is a lack of clear recommendations by professional society guidelines. This also explains the marked heterogeneity in responses of clinicians to various questions of our survey. This reinforces the need for universal recommendations by professional societies related to all aspects of SDF testing in the evaluation and management of infertile men, including technical aspects and cutoff points. Before I end, I just want to give you some take-home points to think about. We know that through several studies, sperm DNA fragmentation is associated with negative pregnancy outcomes. SDF testing can be useful in patients with idiopathic male infertility, unexplained male infertility, recurrent pregnancy loss, clinical varicocele, previous ART failure, and those with lifestyle or environmental risk factors. We need updated guidelines and recommendations from major professional societies, as well as high-quality studies on SDF. It's likely that SDF may be a plausible explanation for a lot of men who are classified as idiopathic infertility or unexplained infertility. And really, in order to move the needle to help this population, we need professional societies to update guidelines and provide clear clinical indications for using these tests and treatment options to help improve men that have elevated SDF. Thank you.